Good evening, ladies and gentlemen. I warmly welcome you to the Saturday Talk series by Sri Lanka Medical Association. Today's speaker is Dr. Lakmal Fonseka. He is a consultant physician with special interest in infectious diseases. He is a senior lecturer in Department of Medicine, Faculty of Medicine, University of Ruhuna. Dr. Lakmal will be delivering the lecture today on treating common infections in your general practice. Over to you, sir.
Yeah, thank you so much. And thank you, SLMA, for giving me this opportunity to speak to you all. And I hope you all having a nice evening. And we are going to spend a bit of time talking about the antibiotics today. So to start off with a case. So let me give you a 55-year-old doctor, a real case, admits to the hospital with 3 days history of fever, signs of pneumonia, and started on the routine antibiotics, ceftriaxone and clarithromycin. But she deteriorated after 6 hours of admission and was started on meropenem and vancomycin. Her oxygen requirement increased further and she required intubation and she has to be put to the ICU and required ventilation, inotropes, and the maximum care was given. A doctor still working in the hospital, but still she succumbed due to the severity of the pneumonia after 72 hours of admission. So later, after this, the blood culture came as MRSA. So let's ask a few questions about this case. This can happen to any of us. So why did she die? And she was started on maximum antibiotics possible, meropenem and vancomycin. You cannot give a better one in our hospitals these days. But still she died. And how did she get MRSA? So let's try to answer these three critical questions. So why did she die? It's simple and straightforward. She had a severe pneumonia and she was started on maximum antibiotics, but why did she die? So it's because she had an MRSA bacteremia. Mind you, MRSA has a good cover with vancomycin, but when you look at the usual Staph aureus, and when you compare with the methicillin-resistant Staph aureus, the mortality rate is higher. So the resistant version of usual MSSA or methicillin-sensitive Staph aureus is MRSA. So in these infections, the mortality is higher. More the resistance, the mortality will be higher, whatever you do. And antibiotics needs time to act. So, ladies and gentlemen, if somebody has a resistant infection, it is proven that they are having a high mortality rate. So how did she get MRSA? Most of us work in hospitals. So whoever works in hospitals have more contact with ESBL, MRSA, these kind of multi-drug resistant patients and their excreta. So we are prone to have these bugs inoculated into our skin, and we can get these infections. So that's why infection control, good hand washing, everything is important to safeguard us from these infections. Case number 2, this again a real case. 15-year-old girl presents to the outpatient department with fever and dysuria. She's having a lobar UTI. She was treated twice with cefixime by a few of our doctors, twice to be fair. And urine culture then wrote ESBL, extended spectrum beta-lactamase producers, sensitive only to meropenem and resistant to all the antibiotics, including cefixime. But she's a 15-year-old, has been perfectly healthy, has not had been in the hospital previously, no comorbidities, no diabetes. So let's ask those critical questions again. Why did she get an ESBL E. coli infection, 15-year-old without any problem? And how did she get that? So let's try to answer these questions. So it's unclear why she got it without comorbidities, but one reason is she has been given cefixime twice in her usual, within the last month. And mind you, ultrasound, everything was done, it was fine, and she did not have a focus. But when somebody receives cefixime, it's a third-generation cephalosporin. It's the oral version of the ceftriaxone or cefotaxime that we use. So if we use this antibiotic in the community setting repeatedly, we are inducing antibiotic resistance, and cefixime will be resistant. And when cefixime is resistant in gram-negative bacteria, you are ending up with the ESBL, extended spectrum beta-lactamase producers. Yeah. So how did she get an ESBL? So if she has got repeated antibiotics, okay, so that has induced her to have a resistant bug than before. So cefixime is not the choice to be given in the first line. So let's learn later what should have been given. So why inappropriate antibiotic prescription should be reduced? That's an important question, because each prescription induces resistance. So ladies and gentlemen, look at this. Let me get the pointer here. So look at this number 1. So in our gut, there are lots of germs, where few are resistant to antibiotics. The blue bacteria are the good, healthy gut microbiome, and you have few resistant bugs in your body, which might be resistant to all the antibiotics, multi-drug resistance. But if somebody gets antibiotic repeatedly, we are always killing these good bacteria, healthy gut microbiome, which protects us from all the infections, and cardiovascular health is maintained by these nice bacteria. So with repeated administration, we are wiping out this nice blue bacteria, and the resistant bugs take over that space, and they grow, multiply, and acquire the space. And when you get an infection next time, you are getting an infection with the resistant bug. So this is the story, how the antibiotics induces resistance. Yeah. So I did recently, last week, with our medical students, we did a small audit in our ward. We looked at how many patients in our ward are on antibiotics and how many people were on the best antibiotic that we have, which is meropenem. So in the female ward, 50% of the patients were on antibiotics, and 1/4 of the patients were on meropenem. Mind you, this is a massive figure. The male ward has done much better. 50% were on antibiotics, but 7% were on meropenem. And what we are doing here is we are using more and more and more meropenem. And what we are doing is inducing resistance to meropenem. And we'll be ending up with infections which are not amenable for meropenem. And in the hospital sector, we don't have an antibiotic better than that. So we are in trouble, ladies and gentlemen. So other misconception that we have in our system is antibiotic resistance do not spread from one person to other. Mind you, if you have gone to a patient who is having chickenpox, you'll be wearing face masks, your PP, personal protective equipment, the gowns and everything, and you'll be really scared that you will get chickenpox. But when we go to a patient who is having MRSA or ESBL, I don't think people take it in that manner. But AMR, the antibiotic resistance or multi-drug resistance, can spread from one person to the other. Look at Mr. Kamal, who is here. Kamal goes to the hospital and receives broad-spectrum antibiotics. And then Kamal goes home and to the community. And if he has MRSA or ESBL in his flora, he will spread that infection into the community. Mind you, some of us work in the hospitals as doctors. So we can also got resistant bacteria inoculated into from the surfaces of the hospital to our skin. And we go to the community and spread the same thing. Mind you, we go to our homes as well. We can do the same thing, spreading these infections to our family and loved ones as well. So this, ladies and gentlemen, is a vicious cycle. More the resistance that we have, the hospital might be culprits in spreading these resistant bugs to the community. Case 3, 37-year-old male having Guillain-Barré syndrome. He did not have any infection when he's coming in. He went to the ICU and he was intubated and he developed a ventilator-associated pneumonia. Don't we see this very commonly these days? Everyone who is intubated gets what we call a VAC. And it's gruesome Acinetobacter, and the patient had a severe pneumonia, septic shock, and succumbed due to sepsis. Mind you, this patient did not admit with a sepsis, but the sepsis was created by the hospital. It's a hospital-acquired infection. So this is for the ICU MO medical officer who were taking care of the patient. He was really sad about this situation. So he said, it is very difficult not to get VAP in the hospital. We are helpless and sometimes feel pointless when patients die due to VAP. With all our efforts, they have done their maximum. They have done their ultra maximum to save this patient, but they are helpless because AMR, antimicrobial resistance, can come into the picture and succumb this patient. What we should learn from these cases, AMR is one of the main killers. It will be increasing in the future. It's one of the the greatest threats to the human existence coined by the WHO. So, and in 2050, it is going to further increase, and it's going to take over it's going to be more than the cancer deaths that we are having these days. So it's going to be 10 million deaths in 2050 in the future. And if you see these large pyramids, the Asia and Africa are the main areas that AMR is going to happen. If you see roughly 4 million of these cases is going to be in Asia, 4 million of these cases are going to happen in Africa, and mind you, other places like the Europe, the North America, Australia, these people have very nice antibiotic usage, rational and limited use of antibiotics. And they have the process called antibiotic stewardship. They govern their antibiotics well, and by that, they have reduced the AMR. And where are we standing? So think about your future, think about your loved ones, and do you prefer to live in a world where bacteria has resistance to antibiotics? Of course, the answer would be no. And aren't we all having a moral obligation to retain the effectiveness to the future generation? So when you look at the general practice, or the what do you call the GP practice, so when we see a lot of patients with viral infections and mildest infections in the community. So when we are treating the patient there, we have to ask 3 basic questions. Is this a viral infection or a bacterial infection? Does it need antibiotics or not? And then ask, what is the appropriate antibiotic? Yeah. So best antibiotic in your general practice is actually no antibiotic. Sorry to disappoint you if you were listening to get the best antibiotic, but it's no antibiotic would be the best option that you would have. And especially if it is a viral infection, you are very clearly it will not work unless for giving some oseltamivir for influenza. So if it is a viral infection, do not give any antibiotic. And the next step is, if it's an infection, a bacterial infection, what is the appropriate antibiotic? Is the access group of antibiotic. I'll let you know in the next slide what is this access group stands for. Then the antibiotic courses. Do not give longer courses of antibiotics. In the usual outpatient practice, it's usually 3 to 5 days of antibiotics would be sufficient. And good patient education and review is very important in these patients. So invite a review after 48 hours, and then you can review these patients. So what is the access group of antibiotic? So in your left, in blue, you see the access group of antibiotic. Amoxicillin, penicillin, cefalexin, cefuroxime, clarithromycin, clindamycin, fluoxetine, doxycycline. So these are cotrimoxazole, trimethoprim, nitrofurantoin. So these are the ones which falls into the access group of antibiotics. And access group is the group that we must use in a general practice, which means outpatient departments of the hospitals, outpatient department in the private hospitals, and any general practice that is done outside. When you go to the community, you will see general practices. So the access group of antibiotics are the ones that we should be using there. So the watch group antibiotics and the reserve group antibiotics, which are here, are reserved for the hospital. So azithromycin, cefixime, ciprofloxacin, levofloxacin, moxifloxacin, these antibiotics are reserved to the hospital to treat severe infections or resistant infections. So these ones should not be used as toffees, basically, in the general practice. So mind you, next time when you see an antibiotic prescription, so in the outpatient department, so you have to see whether it falls into the access group of antibiotics. So the access group of antibiotics are given in a circular issued by the health ministry. So now it is an accepted thing all over the country, and this is the practice that we must use in the future. So access group of antibiotics have a narrow spectrum, low cost, and very good safety. And they are often recommended as empirical first choice treatment, which has a best therapeutic value, and it has a minimal potential for developing or inducing resistance. This is the important point, ladies and gentlemen. And watch and reserve group antibiotics are reserved for inpatient treatment. So viral and bacterial, how you differentiate? It's very easy. Viral infections often have a contact history. The family members have severe symptoms, and they have rhinorrhea, and they have vital signs are completely normal, CRP is low, and you don't see a focus of infection. You examine the lungs, abdomen, and everything, and you don't see a focus of infection. But important thing that we have to be mindful in Sri Lanka is dengue fever. So be mindful about that. And bacterial infections, usually it has a focus. You have respiratory focus, it can be urinary, it can be cellulitis, and the vital signs will be altered. And there is significantly risen CRP, and the patient might be having uncontrolled diabetes, immunosuppression, neutropenia. So if those are there, you have to think of a bacterial infection. So only bacterial infections require prescription of antibiotic. That's an important fact. And antibiotics does not improve or reduce the duration of viral infections. We have seen most people are receiving prophylactic sort of antibiotics, but it's not indicated at all. Do not prescribe it. And the SLMA story has come across many times in our practices. And in Sri Lanka, it's very loosely used. It can be sore throat, frontal headache, it can be chest pain, back pain, cough, ear fullness, or anything like that. People can come, mata semati and all that. So dig deep into the history and see whether it is really an infection. Most of this patient it's not an infection. It's so-called SLMA. It does not equalize to infection. So look for alternative diagnosis other than infection as well. I recently came across patients who have been treated for sinusitis, many courses of antibiotics, but the patient is having tension headache. So a patient having cough, it can be post-viral wheezing or bronchitis or bronchial asthma or COPD. So you look for alternative diagnosis as well, not only think about infection. And we have seen antibiotics are prescribed just as another drug. So sometimes patients think, okay, there should be 4 or 5 drugs. Okay, sometimes the doctor might think, okay, let's put an antibiotic after 5th one. Don't do that, ladies and gentlemen. Antibiotic is a special group of drugs. It's even not like metformin or enalapril or any other drug that you use. This antibiotics gives rise to resistance. So metformin, there is no metformin resistance or enalapril resistance, but antibiotics will become resistant with frequent use of it. So let me go through a few cases. What antibiotics are preferred to be used in general practice? So wake up, ladies and gentlemen, and try to answer this question. So 32-year-old female present with sore throat, painful swallowing for a few days. Also having a cough. Examination, afebrile, tender cervical lymphadenopathy, no tonsillar exudates. How would you manage this patient? If you can send some answers to the chat box, I would be really happy to see what your thoughts are. Yeah, your thought is correct. It's just paracetamol, or you can give some antihistamines or anything like that. So this is a case of pharyngitis. So how to differentiate whether it is bacterial or viral? It's very easy. So 95% of the time, it's a viral origin. So very limited patients only develop bacterial infections. They have a severe presentation. They have very high fever, more than 38 degrees. They have tender cervical lymph nodes and pharyngeal exudates. You will see these yellowish spots. So one on the right side that you always see is a viral infection. So the group A streptococcus is like 5% of the chance of having that. And we usually use this Centaur clinical scoring system to see whether it is a GAS, means group A streptococcal infection. So if the patient is having a score of 3 or 4, having fever, no cough, tender cervical lymph nodes, tonsillar exudates. So to keep it stupidly simple, so if there are lymph nodes, if there are tonsillar yellowish plaques or tonsillar exudates, then you can give an antibiotic for pharyngitis. Otherwise, it's not necessary. So what's the treatment? So viral infection, no antibiotic care. Not giving antibiotic, ladies and gentlemen, it does not mean you are not caring the patient. So no antibiotic care is still caring the patient. Okay, so there you can give paracetamol, antihistamines, reassure, educate, and say it's going to stay there for 5 to 7 days. A good salt water gargle and some steam inhalation and some good old Kothamali, and you will get better. So indications to treat antibiotic is the ones that I mentioned before. If there are tender cervical lymph nodes, pharyngeal exudates, you can consider an antibiotic. And what's the best antibiotic you have for pharyngitis is amoxicillin. The best is penicillin because the group A streptococcus is sensitive to penicillin, but it has a very difficult regime. Maybe I have to give like 6 hours. So amoxicillin would be fine. So give it for like 5 days. So if allergy of penicillin, you can use the other one, cephalexin or clarithromycin. So there's a myth that amoxicillin does not work anymore. It's false. It's a misunderstanding. For sore throat, amoxicillin. Another case. So 66-year-old man, uncontrolled diabetes, feeling unwell for 1 week, worsening chest pain, productive cough, temperature, respiratory rate is high, 32, blood pressure is 120/60, bronchial breathing and crepitations in the low zone. What is your preferred course of action? Can I see another set of answers? Yeah. So it's number 5. So we introduced this score called CRB65. So instead of CURB65, we often does not have urea in the outpatient department, and also in the hospital we don't have it. As sometimes you can use this CRB65 score, and if it is 2, therefore you need to refer to the hospital immediately. But I will let you know in the next slide what should we do. So you can see this patient is clearly having a pneumonia. Respiratory rate is high, no confusion, blood pressure is fine. So respiratory rate is high, the age is high. So that's why CRB65 is 2. So you all know how to diagnose a pneumonia, new onset worsening cough with fever, sputum, and you will see localizing lung auscultatory findings. You have crepitations, you have increased respiratory rate, you have tachypnea. So look for these clinical findings carefully in your examination. So what would you do? You don't need to do any imaging or any testing. You can do a full blood count CRP if you wish. And if it looks like viral, you can ask for influenza, or SARS-CoV-2 might not be useful now because unless in immunocompromised person. So CRB65, on your right side, you see that presence of new onset confusion, respiratory rate more than 30, low blood pressure, and age 65. So this is the way you calculate the CRB65 score. And if it is zero, and you still see localized crepitations, you can still use amoxicillin. So it's a myth that we are having in our mind that amoxicillin does not work. Mind you, this is 1 gram TDS, not 500 TDS. 1 gram TDS of amoxicillin should be used in patients who are having a CRB65 score is 0. Okay. And alternatively, you can use doxycycline as well. Some people tend to use doxycycline, 100 BD for 5 days. So you can use these 2 antibiotics if the CRB65 score is 0. If the score is 1, so one of these parameters are altered, then you can use this. You can consider inpatient treatment, but if you have good clinical judgment, you can use comoxiclav, clarithromycin, or comoxiclav, doxycycline, and you might be able to prevent an admission by doing this. But if it is 2 or more, you have to refer the patient to the hospital and will need further care there. Or if the patient is immunosuppressed, elderly, uncontrolled diabetes, or malignancy in the background, these are red flag signs. These patients would be anyway, it's best to refer them to the hospital because they can worsen their clinical symptoms quite fast. So next case. A 30-year-old man with no significant past in medical history asks you to, this is a common thing that you see in the day-to-day practice these days, asks you to prescribe an antibiotic. Don't we all always come across that? People ask for antibiotics. After presenting with troublesome productive cough, she had fever initially. So she had fever for initial 2 days, followed up with a troublesome productive cough. I would say like a barking sort of a cough. And all began with a runny nose. Sputum was scanty, but he said it's yellowish, and that's why he wants an antibiotic. And on examination, he was relatively well-looking. Vital signs were normal, include respiratory rate, chest examination was normal, and what is the correct course of action? Can I see another set of answers? That's quick answers, ladies and gentlemen. Very well done. So its answer is B, give symptomatic treatment, advice, and information about the condition. So we next we'll find out what are the important things that we should tell the patient. So diagnosis here is a bronchitis. This is extremely common these days. Post-viral bronchitis is extremely common, and antibiotics are basically abused, not used, but in front there's a AB, abused, basically abused these days because of bronchitis. So acute onset troublesome cough lasting for more than 5 days. Sometimes it's like a barking type cough, can have a scanty amount of sputum, and sometimes they might have yellow, green, brown, different colors like the rainbow, and it does not indicate a bacterial infection. So caused by respiratory viruses. An important thing to ask in bronchitis is whether the patient had a preceding viral illness. It is most likely, it's obvious that they have a viral infection. Might be a tiny bit of sore throat, a tiny bit of runny nose, or a fever in the beginning, and then followed up with the bronchitis. The fever settles, but the cough persists. So it's usually a mild infection, no systemic signs of infection, and good examination is good assessment of respiratory rate is very important. Respiratory rate is completely fine, no lung signs, and you have to educate the patient well. You have to give reassurance that there is no pneumonia here. That is the main fact that patients are waiting to hear. So they are afraid that this is a pneumonia. So good clinical examination and assessment is very important, pertinent to diagnose bronchitis, ladies and gentlemen. So if it is a pneumonia, it's a severe presentation. They will have high fever, shortness of breath, systemic signs. The patient is ill-looking, and heart rate is high, respiratory rate is high. You will have the patient will have localized crepitations, and then you treat as the example that I given before this. So important details to give to the patient is it's a self-limiting illness. Antibiotics is not going to help or reduce the duration or the severity of bronchitis, and reassure the patient that the cough will last 3 weeks. So 20 days is the figure. So roughly say it's going to last 3 weeks, and it will have a gradual improvement, not a rapid improvement that you see like a bronchial asthma or something like that. Right. So what is the investigation? You don't need to ask for any investigation. Just symptomatic treatment. You can give some ibuprofen, cough syrup, and sometimes a short course of inhaled steroids are important. I use inhaler which has budesonide or beclomethasone or something like that. And you can give a mucolytic, antihistamines, and good patient reassurance and say that it is for 3 weeks is very important. And antibiotics are anyway not recommended in bronchitis. We move on to the next case. 25-year-old female who was treated for upper respiratory tract infection recently is now presenting with left-sided headache, facial pain, nasal congestion for 1 week duration. Does not complain of fever or but has intermittent dry cough. So what's your preferred strategy? So what do you think is the best thing to do here? Great answers, everyone. So yes, you prescribe medication for symptomatic relief, antipyretic and analgesics, nasal decongestant. So I think the diagnosis is clear. This is a case of acute sinusitis. So acute viral sinusitis is the most common. Sometimes they might have nasal drainage. They might have mucopurulent rhinitis. When somebody blows their nose, they can get some, the pus or something, it's like infected material or something like that. It does not indicate the patient is having a bacterial infection. The viral infections causes inflammations in the sinuses, but it carries over forward. And then they have these mucopurulent secretions coming in. So if the patient, so let's see when do they need an antibiotic. So most likely the patient is going to have a viral sinusitis. It's going to take 10 to 14 days to recover, and it's usually self-limiting. So acute bacterial sinus is less than 2% of all the acute sinusitis that we see. So if the symptoms and signs are persisting, I would say beyond, you can get a lesser figure by 7 days. It's easier to, if it is going beyond a week or something like that without improvement. And if there's a significant worsening of symptoms after initial mild phase. So in those instances, you can treat with antibiotics. And other than that, if there are these red flag signs, systemic toxicity, persistent fever, periorbital redness swelling, severe headache, altered menses. So if there are these toxic symptoms, then you can give an antibiotic for this patient. So purulent discharge alone or purulent rhinitis alone is not an indication for antibiotic. If it goes beyond 7 days, then you can consider an antibiotic. So what's the best treatment option that you have? So you can again give amoxicillin. So depending on the severity, you can use either 500 3 times a day or even 1 gram 3 times a day, or else you can use clarithromycin for 5 days. So if there is poor response, if somebody has given amoxicillin or clarithromycin, if the patient is coming back, then in this case, you can use some comoxiclav. So it's a second-line antibiotic, not the first line. Then we go to the next case. Another important case, which is very common these days, we are having some good rain in Gaul, and we see an outbreak of diarrhea these days. So 27-year-old patient presented with watery diarrhea 15 times a day, cramp in abdominal pain, nausea for 2 days, claims that he has taken some street food 3 days back. On examination, was afebrile, conscious and rational, no dehydration. So, and how would you manage this patient? It's quite straightforward. So in this instance, you give ORS, electrolyte replacement, and send home. So what is the, when do you want to start an antibiotic in this patient? So most acute infectious gastroenteritis does not need any antibiotic. The diarrheas, they don't need antibiotic most of the time. Even mild, even if you think it's bacteria, if it is mild, you don't need to treat with antibiotics. It will be getting better on its own. So causative organisms, if it is watery diarrhea, you are clear that this is a viral infection. If it is a blood and mucus diarrhea, then you can think of considering an antibiotic if it is severe. So investigations in the outpatient department, you don't need much investigation, but you go to the treatment. So rehydration, electrolyte replacement is very important. Mostly what they come to the hospitals are when they are dehydrated, they are not feeling well because their electrolytes there's an imbalance in the electrolytes, and mild to moderate infections. You don't need antibiotic, you need supportive care. And when do you give an antibiotic? This is an important thing. So if there's acute blood and mucus diarrhea with fever, persistent diarrhea which is not improving for 7 days, or else if the patient's quality of life incapacity has happened due to the diarrhea, then if it is like really increased amount of diarrhea, then you can use that. Yeah. So next, what is the antibiotic option? So in the so there are most likely what people use is ciprofloxacin for this thing, for diarrheas, but most of the ciprofloxacin, because of the huge use of it, becomes resistant. So, and because of the clarithromycin or azithromycin would be the good options here. So these are the doses that we use. And so these are the two antibiotics that we can recommend, because quinolones or the ciprofloxacin is in the group of levofloxacin and moxifloxacin, and these are the drugs that we commonly use for TB. So if you are a country who's having a lot of TB, so in that case, it will be very disastrous if the TB becomes resistant and we are having MDR TB. So in that case, best thing is to give clarithromycin or azithromycin in this case. Another case, 25-year-old woman presented with symptoms of urinary tract infection. And urine sample was sent, which shows E. coli ESBL, resistant to comoxiclav, ceftriaxone, but sensitive to cotrimoxazole, nitrofurantoin, or gentamicin. Right. What is your preferred course of action, ladies and gentlemen? Yeah. So let's look at the answers. So there's a mixture of answers at the moment. So 1 and 2. So what's the correct answer? It's actually 2 or 4. So this is actually a lower UTI. Although it's a resistant infection, we have a good oral antibiotic that we have. And you see, it's a lower UTI, so it's not a severe infection, it's not pyelonephritis. So we can safely treat these patients in the outpatient setting. And we have good antibiotics, nitrofurantoin and cotrimoxazole. Right. So all know about how to diagnose the lower UTI, so I won't go ahead with that. Lower urinary tract infection, the most common bacteria, Enterobacterus, mostly E. coli and Klebsiella. And so what's the antibiotic option? I would say the best antibiotic option is the nitrofurantoin. So because in Sri Lanka, there's a lot of ESBLs in urine cultures, and nitrofurantoin has a good ESBL cover. So that's an oral antibiotic which has the best ESBL cover, and it is great for lower UTIs, and it is concentrated well in the urine. Well, so in that case, you can use nitrofurantoin 56 hourly, or sometimes some countries actually have a sustained release formulations as well. So in that case, you can use 100 BD as well for the ease of taking the medication. And trimethoprim, cotrimoxazole can also be used. So these are shorter courses of cotrimoxazole, so you don't have to worry about having kidney problems or liver problems or anything. I use cotrimoxazole a lot, and only thing you have to say, if there's a rash or anything like that, you just stop it and come to the hospital. But that's the one that I use in second to the nitrofurantoin, and if it is a very safe drug and works very well. So another brainstorming session. So is this the right choice of antibiotic? Fever and sore throat. I have seen many people actually taking azithromycin as the gold standard, but it is not. It's wrong to take azithromycin for fever and sore throat. So, and I have seen some prescription, ciprofloxacin is given for sore throat. Maybe it's because it's a cheaper drug. For God's sake, do not use ciprofloxacin for sore throats. And fever and cough, thinking of a pneumonia, do not use levofloxacin in the outpatient setting. You are exhausting the levofloxacin that we must use in the hospital. And cellulitis, chlormoxiclav, clindamycin, no. Use flucloxacillin, which is the gold standard. And you can use 1 gram 6 hourly, not 500 6 hourly. You can use a higher dose. 1 gram 6 hourly works very well for cellulitis. Lower UTIs, the best is nitrofurantoin or cotrimoxazole. So azithromycin, reserve it for like bad atypical pneumonias, salmonella. So instead, for fever and sore throat, use amoxicillin. So sore throat, do not use this. Ciprofloxacin are great for ESBL UTIs and resistant pneumonias. And it's in the quinolone group, and it's in the TB drug armamentarium with levofloxacin and moxifloxacin. So use amoxicillin. So do not use levofloxacin. It's great for poorly responding pneumonias and hospital-acquired pneumonias. So use something instead. Cellulitis, do not use this. The clindamycin or chlormoxiclav is great for people who are having uncontrolled diabetic foot infections and necrotizing fasciitis, that sort of instances. So best to use flucloxacillin and use the high dose, 1 gram 6 hourly. That works very well. And lower UTIs, do not use cefixime. You are inducing the ESBLs. Don't do that. We have problems with the ESBL, and the only option might be meropenem. So do not use cefixime. It's great for pneumonias and pyelonephritis as an oral switch from IV, from ceftriaxone to another one. So, so use nitrofurantoin and Cotrim, and mind you, nitrofurantoin, both of them have a ESBL cover. So what not to use in the primary care OPD level, that is the thing that we should understand. So do not use cefixime, levofloxacin, moxifloxacin as first line. Ladies and gentlemen, do not do that. And limit the use of azithromycin and ciprofloxacin. These should be taken, with great caution. Do not use it for sore throats. Never do that. And comoxiclav also, we have to reduce usage because we use it commonly for pneumonias and pyelonephritis in the hospital. So try to limit those things, because more you use an antibiotic, the earlier that you will reach resistance. So the less you use, you can use it for a prolonged duration and for a great cause. So what is unique about antibiotics? That I think we understand it now. So other drugs have individual effect. Metformin will cause diabetes control in that individual patient. And you can give it for lifelong without any problem. It will not cause resistance to metformin or something like that. It's never heard of. But antibiotics have an individual plus a community impact through antibiotic resistance. So you have to think about AMR, antibiotic resistance, when you are giving a prescription. Think about whether you are using it for a proper cause, a great cause of treating an infection. It should not be used in uncontrolled fashion. It should be used rationally. So there should be a rational prescription of antibiotics. And because of that, every antibiotic prescription counts. So try to answer these 3 questions, whether it is a viral infection or bacterial infection. So master the clinical skills to differentiate viral from bacterial. It takes a bit of time. You cannot, it just not comes with just genetics. You have to just master that. You have to think about it carefully, give some thought, give some skill, and then identify in your practice whether it is viral or bacterial. And with time, you will be experts. When the patient walks from the door, you know it's a viral infection. And does it need an antibiotic or not? That's again, you have to ask, because antibiotics is not always necessary. And whether it needs antibiotic or not, that you have to decide. And what is the appropriate antibiotic? That is the access group in the AWARE classification. I repeat it again, the access group of antibiotics in the AWARE classification. So these are the narrow spectrum, very safe ones, which have least potential to induce antibiotic resistance. And because in the general practice, what we usually see is very mild infections. So these are mostly viral, but sometimes you might get a very mild bacterial infection. So some misunderstanding. Some people think the amoxicillin does not work for sore throat and pneumonias now. So in the outpatient setting, it still can be used. It works well in the outpatient setting. So levofloxacin, ciprofloxacin, cefixime are better first-line choices of antibiotic. No, it's a big no, because I'm fortunate that nobody has produced an oral meropenem. So if there has been an oral meropenem, people would have been using that judiciously, because you can, unlike the other drugs like in diabetes or hypertension or anything like that, you cannot use the broader spectrum antibiotic that you have available in the armamentarium of in the antibiotic groups. You cannot use that, because the broader spectrum, if it becomes resistant, you are left with nothing at the end. So we will be going to not the pre-antibiotic, it's something similar to the pre-antibiotic era. It will be post-antibiotic era. We'll be just relying on sunlight or air or something like that to cure our infections. And there's another misunderstanding that an AMR does not spread from one person to the other. It spreads. So if somebody is a patient who's having a severe infection come home, so that patient, I think it's important to have some infection prevention measures as well, because those resistant bugs can spread from one person to the other. And it is safe to give antibiotics to prevent bacterial infections? No. So do not use antibiotics prophylactically. Have the skill of deciding when a bacterial infection starts. And especially in milder infections, you have ample amount of time to decide whether the patient needs an antibiotic or not. You have ample amount of time. But unlike in a hospital setting, if the patient is coming with septic shock or very ill, low blood pressure or anything like that, then you don't have time to differentiate. Then in those situations, you can give the best antibiotic that you have. That's perfectly fine. You have to save the patient's life. In mild infections, you don't have to do that. So another food for thought, would you treat these occasions differently? At your practice, you see a 30-year-old having fever, runny nose, and sore throat, and he requests an antibiotic. So there's a pressure to prescribe an antibiotic. So would you prescribe an antibiotic for that person or not? I would not. I would not prescribe an antibiotic. I would respect his request. I will not dismiss or bring down his request. I would respect his request and educate the patient well. I'm confident that this is a viral infection and you don't need an antibiotic. And if he requests further, you can say, okay, you can come to me again in about 2 days. We'll reassess and see whether you need an antibiotic. And it will be getting better in 48 hours. And mind you, don't prescribe antibiotics on first day of these mild infections. Don't be a one-shot doctor. It's not justified to be like that. Be a guardian of antibiotic guardian. And sometimes when you grow bigger and you have your own child, 10-year-old, having fever, runny nose, and sore throat, so would you be keen to give an antibiotic to this child? I asked from several people and they said, okay, for my child, I would not give antibiotic because it's not good for the gut microbiome. But what about the person in the society? Is it justifiable to give an antibiotic for that person in the society and destroy that person's gut microbiome? It's not nice to do that. 25-year-old student coming from United Kingdom, having fever, runny nose, and sore throat. Of course, if you ask from this person, I'm giving you a prescribe. Most of the doctors they are afraid to prescribe an antibiotic for that student coming from UK. That person will definitely ask, so this is a viral infection, why you are giving him an antibiotic? They will definitely question that, because their society has understood the gravity of AMR. They have understood the gravity of antimicrobial resistance. And a medical student having fever, a familiar scenario, having fever, runny nose, and sore throat for 2 days, and doing prof unit appointment, have to run to the prof unit. You cannot be absent, and you might get penalized. So what are you going to do? But still, I think best to take some symptomatic relief, and maybe it's best to take 1 day's leave rather than giving it for giving that gift to all your friends and making everybody else ill. So it's not, you don't have to take an antibiotic. Right. So the unity of everyone in this community, the doctors and the healthcare workers, outpatient or inpatient, or from consultant to the house officer and all the general practitioners. So all of us need to work together to fight AMR. Otherwise, we cannot win this. The bacteria are more smarter. They are getting resistance with each day, and they are getting resistant at a faster pace as well. So because of that, the production of antibiotics has not become a very lucrative field. Because when you produce a drug spending billions of dollars, then that antibiotic becomes resistant. So there are few antibiotics which are produced over the last few years, and naturally the bacteria are way smarter than us. So we have to all get together to fight AMR. There's no other way of winning this. Thank you so much. And if you have further questions, you can email this saveantibioticsforfuture@gmail.com. That's one of my emails. So, and also I'm happy to answer any questions. Thank you so much.
Thank you, sir, for that informative talk. We can discuss few questions from the chat as time permits. So that was one question. Yeah. So 22-year-old girl presented with recurrent dysuria and abdominal pain, UFR pus cells, awaiting for culture. Which empirical antibiotic can be started?
Yeah. So I'm reading this as recurrent dysuria and abdominal pain. And it all depends on the symptomatology. First, get the diagnosis: fever, ill, dysuria, low abdominal pain. So this looks like if it's dysuria, it's like urethritis or a lower UTI. So so naturally, as I said, nitrofurantoin would be the best choice. But if it is recurrent dysuria, if the patient is having, so a 22-year-old, it's very unlikely for that person to have recurrent infections. Look at, maybe it's best to look at the pus cells, number of pus cells. Sometimes they come as like 10 to 15, and it does not mean that the patient is having infection. So as these patients are well, what I would do is just wait for 2 days. You send a culture, wait for 2 days until the culture pops up. So most of these instances that I've seen in young people, fit people, they are actually not having infection there. They are just having dysuria, dehydration, or maybe has received some medication, and it's not an infection. So if you're sure that's an infection, I would give nitrofurantoin.
Okay, so the next question is how to decide the optimal duration of antibiotic use?
Yeah, so that's a really good question. So that's why we have the guidelines. And so if you are looking at the hospital infections, so if you look at the antimicrobial guidelines in 2024, you can see the optimum duration of antibiotic. So stick to that. And if you are an outpatient prescriber, if you are treating mild infections, 3 to 5 days is the one I use. So always 3 to 5 days. If it is a mild infection, all of these are mild infections. So mildest of the mild infections, I give 3 days. So if you think it's a little tiny bit severe, but still within mild, so I use 5 days. So in the outpatient setting, I would say 3 to 5 days. And inpatient setting, you can stick to the antimicrobial guidelines. And naturally for lower UTIs, 3 days of antibiotics is enough. That's the duration which I use.
Okay, the next question is commonly we see UFR positive without symptoms. Should we treat?
I would not treat those patients because if somebody is very healthy and does not have any symptoms, just UFR positive, if the person is very young and healthy person, I would not treat. But imagine this patient is on immunosuppressant or having neutropenia or, maybe in pregnancy or something like that. So in those instances, I think it's best to send a urine culture and then decide on thinking. So if it is a young, fit, healthy person having just a positive UFR is also depends on how much of process that you have. So, and what's the sample that you get. So if it is a catheter sample, it might be not very very relevant as well if somebody is like fine. And if somebody is having a low amount of pus cells, no symptoms, though, so then I would not embark on giving an antibiotic. So the safest way is to reassure the patient, send a urine culture and review the patient in about, give an open review in about 2 days. So the culture report pops up. And or if you don't have luxury of culture reports, you can just review the patient in 2 days with some symptomatic treatment.
Okay, so the next question is, for the case of the woman with UTI and fever with chills, why wasn't the upper UTI suspected?
So upper UTI, you will have fever, systemic illness with vomiting and nausea, vomiting, and you will have a tenderness in the renal angle. So in those instances, you suspect a pyelonephritis, and they can have tachycardia, hypertension, and all these things as well. So if you don't have such features of pyelonephritis, mainly renal angle tenderness, you don't have to consider upper UTI. So lower abdominal tenderness, suprapubic tenderness, and a dysuria with infection syndrome would be a lower UTI.
Can we treat symptoms of lower UTI in females in reproductive age without investigations?
Of course, yes. So females of reproductive age, yes. So anyone under the sun. So if somebody has a lower UTI, can you, Kaushik, can you tell me, is it without investigation? Is that the question that was asked?
Yes, yeah, without investigations.
Yeah. So in all these, the common infection categories, most of them does not need any investigation because these are mildest infections. You don't need any investigation. But always, as in the case that if you have the luxury of doing a uriniform report, best to do one and just to confirm. And you can start on the relevant antibiotic. If you have the good infection syndrome, fever, dysuria, lower abdominal pain, or fever and dysuria, you know that it falls in lower UTI. You can ask the patient to get a UFR done, and you can treat with 3 days of nitrofurantoin or cotrimoxazole. So if you have the luxury, it's best to do that. But if you see, like the question before, if somebody's having a recurrent dysuria or anything like that, I would do both UFR and urine culture.
Okay, the next question, is it appropriate to use oral penicillin for bacterial pharyngitis and cellulitis?
Bacterial pharyngitis, yes, oral penicillin is the best choice that you have because the group A streptococci are sensitive to penicillin. But for the ease of use, what we use is like amoxicillin. The cellulitis, penicillin is not a good choice because the flucloxacillin is the best choice because penicillin will have group A streptococcus cover, but cellulitis is caused by 2 main bugs, which are group A streptococcus plus Staph aureus. So penicillin does not have Staph aureus cover. Okay, so to cover both, the flucloxacillin is, or cloxacillin or flucloxacillin, either of those two would be the best choice.
Okay, what are the antibiotics which cannot be used in pediatric patients?
That's a difficult question for adult medicine
Yes.
consultant to ask. So what I can do is, so we are in the process of making a guideline for general practitioners, and we are in the future we will be launching it with the pediatrics and adult infection covering both. So we'll be mentioning in that, but the except for the lower UTI antibiotics I have mentioned, because in children, people tend to use cephalexin for UTI more than nitrofurantoin or cotrimoxazole. So this is main what I, as an adult medicine, good that somebody asked this question. So all the other ones, it's fine to use amoxicillin and formosclav. It's fine to use that. But the infections are a bit different because children does get bronchiolitis. Again, it's the adult form is like bronchitis, and again no antibiotics for them. So in the UTI would be the different one mainly, and the children don't get cellulitis much. So basically, the except for the UTI ones, other ones would be fine.
Okay, sir. How about the use of steroids in upper respiratory tract infection? Dexamethasone and prednisolone.
Yes. So I would say in a very inflamed throat, viral infection, and if you say a viral bronchitis, you say the inflammation is profound inflammation, you can use oral steroids. So what I tend to do is you can use dexamethasone for a shorter duration, a 1-day course, maybe something like that. So it's evidence-based as well that you can use some dexamethasone for a day. So for a pharyngitis, I would suggest to use dexamethasone for a day, maybe 1 gram BD, or in the trials they have used a very high dose, like altogether 4 milligrams. And for bronchitis, I would say the oral steroids are not much very effective. So I would use the inhaled steroid to get the drug directly into the respiratory mucosa. That's much more effective.
Okay, sir. So what is recommended antibiotic for pregnant lady with UTI?
Pregnant lady with UTIs, I think those patients, again, so it depends on the trimester as well. So I would say using cephalexin would be a good choice. But in pregnant ladies, what is important is there are other categories such as asymptomatic bacteriuria. So they might not have symptoms. You might come across the UFR, but it's invariably you have to send a urine culture and you have to give antibiotics depending on the urine culture. Okay. So, and urine culture guided by the urine culture. A person who is symptomatic with a UTI, so then it depends on the trimester that you are treating. As an example, nitrofurantoin would not be given in the 3rd trimester because it can induce neonatal hemolysis. So best to use something like cephalexin initially.
Okay, so there's another question. In diabetic patient with cellulitis, CRP of 135, high WBC, with neutrophils, should we continue flucloxacillin till CRP is negative?
CRP is the last
negative.
one?
Negative. As in low CRP must be.
But it says initially it's 135.
35, yeah.
So a diabetic having a cellulitis with a high CRP, is it?
Yes, high WBC as well with neutrophils.
Okay, so what I do is in these instances is, okay, you diagnose cellulitis, you identify that the patient is diabetic, and whether but also see whether the patient is having uncontrolled diabetes or controlled diabetes. A very controlled diabetic having a cellulitis, you can give IV flucloxacillin, and you just have to wait for the response, see whether skin wrinkling, and if the skin wrinkling is there, you are heading in the right direction. But if it is uncontrolled diabetic having a cellulitis, it's best to add some gram-negative cover there, because the infections are mostly polymicrobial and they might have anaerobic infections. So comoxiclav would be a good choice there, because it will have gram-negative cover and anaerobic cover, and you will be giving good cover. But if the patient is not having diabetic, not immunosuppressed, and not having any abscess formation or anything like that, just superficial cellulitis, I would give IV In the ward setting, I will give IV flucloxacillin. I would give a higher dose, like 1 gram 6 hourly. 500
Yes.
6 hourly might not be very effective. So give 1 gram 6 hourly and look for a response. If you have those like features, you can escalate the antibiotic.
Okay, there's another SBR. A 21-year-old marathon runner was admitted with acute Achilles tendon rupture. The patient was recently taken an antibiotic for an upper respiratory tract infection. Which antibiotic may have contributed to the tendon rupture?
Yeah,
Amoxicillin.
tendon
Yeah,
rupture
so,
is only comes with the quinolones, ciprofloxacin. But I am
okay,
not sure why that person receives ciprofloxacin.
okay. Then
So this
what is the
tendon
best?
rupture, it's the research has shown tendon rupture in some people have happened sometimes even after several hours of administration to several days after administration. So there's a big duration behind this. But marathon runner, it might not be related to anything as well. You know, if somebody has not exercised and run, you know, then but if you want an antibiotic, that's a ciprofloxacin.
Okay. And what is the best prophylactic antibiotic for cellulitis?
You don't give prophylactic antibiotic.
Okay.
Or if you want, the patient, if you want to rephrase that question as a recurrent cellulitis, so then you might choose to give a prophylactic antibiotic. But I will tell you the rationale of nowadays what the thinking is. So best way to prevent cellulitis is good advice on foot care, treat the fungal interdigital fungal infections, good moisturizer, and keep the skin not cracked. If there are cracked skin or something like that, can be the portal of entry. So best thing is that. But as somebody suggested, penicillin is the one that we use. But you know that Staph aureus does not covered by penicillin. So by giving penicillin prophylaxis, you might be essentially reducing the group A Streptococcus related cellulitis, but not Staph aureus related cellulitis. So if somebody is having a recurrent cellulitis, foot care, treat fungal infections, treat the cracked skin or portal of entry first, and then if it is real recurrent, you can think of penicillin prophylaxis.
Okay, as we are running out of time, we can get one more question. What is the latest guideline we can use for antibiotics and how can we access it?
Latest guideline in the inpatient setting is the College of Microbiology has launched the recent guideline, which is great news for us. So 2024 antimicrobial guidelines is out now. It's launched very recently and it's available in the College of Microbiology website. So you can access that and download that. And that would be the best choice at the moment.
Okay, sir. So that with that final question, we would like to conclude this session today. And as the Council of the SLMA, we would like to thank Dr. Lakmal Fonseka for accepting our invitation today. And thank you everyone for joining the Saturday talk tonight. Good night.
Thank you so much for inviting. Thank you.